Welcome to the August 5th session of the monthly Vatech webinar education series. I am Jim Mayer, Education Team Director for North America. I have the pleasure of working each month with Paul Satone, our West Coast Education Specialist. Welcome, Paul.
Thanks, Jim. Great to be back. Looking forward to this awesome webinar we have for you all today. So it should be really informative and great. So I'm looking forward to this one.
Yes, for sure. We started this education series back the 1st of April. We're almost on our 11th or 12th session. So for those of you who have joined us in the past, welcome again. For anyone who is their first time joining us, we thank you. And we do have all of our recorded sessions on our Vatech America website. Paul, what do we have going on for today? What is our topic for today?
So today we have Sal Rodas from Sleep Architects with us to discuss in detail, CBCT and sleep disorders. So we get great agenda here and lots of information.
Yeah, so our past sessions that we started with back in April, we did some Vatech software. We moved into total health dentistry, looking at the patient's overall dental health. We brought on Dr. Dale Miles, where we looked at 2D to 3D transition within the dental office. Also looking at pathologies, common pathologies with Dr. Dale Miles, and that was last month, which I think directly ties into this, issues in the sinus, paranasal sinus and things. So I think we're really going to expound on what we've covered and how this all ties together in today's session. So really excited session for today. Paul, monthly webinar series, we will be back in September. And we're going to continue on with Airway.
Yeah, so Wednesday, September 2nd, again, the first Wednesday of the month. We want to keep it consistent. So we'll have Sal back with us with Dr. Payam Atai and Sleep Architects discussing really the business of sleep dentistry. So definitely a continuation of this one and just kind of step-by-step process with all our Vatech webinars.
Yeah, building from today's session into the next, how are we implementing? So Sal's going to talk more about that when we bring him on. We do have our new Learning Center, learning series, which is on Fridays. We're calling it Fast Track Fridays. The next one is August 21st. These are the short hour-and-a-half sessions, and we welcome doctor and staff for all these. We really want to engage the staff in your offices for these sessions. Paul, tell us about these 3 different series that we have, or 3 individual sessions monthly on the first Friday of the month.
Yeah, so we're going to be doing our 3rd Fast Track Friday series. We're doing it on Friday this month, the 3rd Friday of the month, like every month. We've expanded it a little bit and changed it a little bit. The first session 1, which is going to be all about patient positioning for 2D and 3D, from 8 a.m. Pacific, start 11 a.m. Eastern. So we're going to have that hour-and-a-half session, and there's going to be a little more interaction. There's going to be breaks in between every 15 or 20 minutes or so with questions that kind of pop in during the session. We're going to take a half-an-hour break and then start session 2, which is going to be 3D software clinical case planning, starting at 10 o'clock Pacific, 1 p.m. Eastern. Again, same format, hour-and-a-half. We're going to take another break, 30-minute break there, and then move on to the advanced Easy 3D implant planning, so just more advanced cases and software features and functions that we will go into that final session for the day there at 12 p.m. Pacific and 3 p.m. Eastern. So
yeah, and we brought this series about as, like I said, very interactive. So our audience, a lot more interaction, kind of changing and melding as the audience asks us questions. We go through some live case planning on session 2, or patient positioning, scanning models, scanning dentures in session 1, looking at pan quality. Session 3, really advanced implant planning. How do I update my implant libraries? A lot of good stuff directly related to the Vatech product line on this session. Yeah.
Right, exactly. And even things that, people may want to go into other things that aren't on the agenda, we can do that. So we have the flexibility to do that too. So it's really a great series.
For sure. All this came out of really feedback from our end users and online, and different ways to communicate with us and be interactive with the Vatech America family.
Yeah.
Some different ways here.
Yeah, so we can always email any feedback for webinars, the sales email address. We have the education email address there. For anything software related, please feel free to email the education team. And then customer support as well as that CS@Vatech America is a really easy way to contact support via email. And of course, our website there. And then also our social channels, Facebook, Instagram, and LinkedIn handle @Vatech America.
For sure. And every month we go through this, it's how to navigate. Everyone should be able to hear us. If you are unable to hear us, please shoot us a message on the Q&A, or what you're going to see now, you should see Paul and I at the top of the screen, and you can see my screen below yours there. You do have the option, if you are having audio issues, to click on the troubleshoot if you're using your onboard computer audio. Just remember, you can always call in, and that's going to be the easiest way to, if you are having any audio issues. Other thing is, you will be muted, but we do have a question and answer session here. So any questions, please feel free to type it down in the question and answer box. Paul and I and our education team will be answering these throughout the session. Sal will also be able to answer those direct questions as we go through the series today. This will run for about an hour, and then we have a Q&A session after the presentation. After Sal's presentation, we're going to go through some software at the very end. We're going to look at what do we have coming up next. And also, there will be CE for this series, so please stick around. Sal will have a slide on how to get that CE towards the end of his presentation, provided by Sleep Architects.
Yeah.
So Paul, tell us about what we're going to be getting into today.
Yeah, so today Sal's going to be, speaking a lot on sleep medicine and airway, and we'll be incorporating CBCT. Starting that discussion, we'll get into the optimal fields of view for the CBCT and what that looks like. We'll discuss the protocol for that, and then we'll look at some of the things in the Easy 3DI software, measuring the airway, visualizing different things within that, and utilizing the software to the best to get what you need out of it for our software.
For sure, definitely. Well, with that, I would like to introduce Mr. Sal Rodas of Sleep Architects, and we're going to go ahead and bring him up on screen now. And Sal, welcome.
Thank you, Jim and Paul.
There we go. Hey, Sal.
Yes.
Yes, radio check.
That's true. We are going to go ahead and share this over to you. Going to make you the presenter. So you should get a message to pop up your screen just like we did before. Welcome and thank you for joining us for today's session, August 5th.
Great. Well, again, thank you, Jim and Paul, for inviting me to present to your audience. And to the audience, good morning, good afternoon, good night. I don't know what part of the world some of you may be connecting from. So I want to make sure we address a global community. And today's presentation is exciting in my opinion because we're dealing with a clear and present danger, and there's an opportunity for you to make a difference in people's lives, and in particular, given the situation that we're dealing with today with the COVID crisis. So I have a lot to present in a short amount of time, so I will move as quickly as I can, and if I'm moving too fast, feel free to make a comment, and either Jim or Paul will interrupt me and I'll slow down if necessary. So, the subject again is the topic of CBCTs and how to incorporate imaging into the process of dealing with patients that may be suffering from sleep-related breathing disorders. So today's event is sponsored by Vatech America and Sleep Architects. And a little bit about myself, I am the Chief Product Officer for Sleep Architects. And Sleep Architects is a medical company that provides services to the dental industry. So my job is to shape the service offering for practices like yours. But I'm also the executive director of a nonprofit organization known as the Foundation for Airway Health. And our job at the Foundation for Airway Health is to educate the public and the medical community at large on the subject of airway deficiencies. I'm also a task force member, one of 13 of the American Dental Association, in putting together the screening protocols to identify children that suffer from sleep disorders. But my journey began by doing research related to concussions. In fact, we presented in front of the International Olympic Committee on Concussions, and we also presented in front of the NFL Concussion Committee, specific to how we could utilize oral devices to reduce the amount of concussive forces that athletes suffered from. And it was during that time and during that research that we learned of the intimate connection between the joint and the airway, and why we need to be looking at both anatomies when we consider dealing with patients that suffer from airway deficiencies, as you will learn today. So here I open up with a quote from an athlete that states that she is an elite marathoner that suffers from sleep issues. And the athlete is Becky Wade, for those of you that may know her. She published this article back in late 2018. And the importance in showing you this is that this is what Becky looks like. And for most of you, and including the general medical community at large, Becky is a young, fit female that would not fit the typical profile of an individual that suffers from sleep disorders. And yet her article, she talks about her struggles as a kid and even today as an elite marathoner, dealing with the issues related with sleep problems, right? Feeling excessively tired. And she gives tips to other runners like herself on how they can mitigate the problems. But you're probably not understanding or seeing some of the physical signs that we see in patients that suffer from airway-related deficiencies. For example, in the case of Becky, you could see that Becky has an upper jaw displacement. You could see some retrorhapnia, but most importantly, you see the long face with that what appears to be a large nose, which are all indications that Becky has a narrow palate and that her nasal passage is impacted, and as a result, she's a mouth breather. And it's consistent with what she wrote in that article, that she's been dealing with these issues since she's been a child, and here she is, a professional athlete, and still having difficulties at night. Because when we talk about breathing disorders, we're talking about a problem that occurs 24 hours a day. The difference is that during daytime, the body adapts, right? We change our posture, we open our mouths. At night, this magnifies because our body is in its most relaxed state. So this is why I like to show Becky, because Becky's life has been shattered as a result of her breathing difficulties. And that's why I want to draw your attention back to the Foundation for Airway Health. It's because as a nonprofit organization, we get a lot of messages from patients that are actively looking for answers. And unfortunately, we do not have enough of you out there educated on the subject of airway deficiencies. So I encourage all of you to visit our website, airwayhealth.org, and that you add yourselves for free as a resource to any patient that's looking for doctors that can help them answer why they feel tired, why their children may be suffering from ADHD or ADD-like symptoms, because these are all interrelated to patients that suffer from airway deficiencies. And having said that, I can't see you, and I don't know who we have connected to the audience, but I wonder how many physicians are actually connected today. And you might be surprised because that's a trick question. Most of you, or all of you, that are dentists are considered physicians as defined by the American Dental Association. And you will note that this definition has also been adopted by every single dental state act that you are probably overseen with. So your license is issued by your dental board, and the dental board has adopted language similar to what you see here. So the ADA describes a DMD or a DDS as a physician. And this is an important distinction when it comes to dealing with patients that suffer from airway deficiencies, because you're actually treating patients through a medical condition, right? Sleep apnea is a medical condition, and therefore you need to follow medical protocols to manage these patients. And don't let that scare you if you've never done sleep, because all it is understanding the process so that you can properly manage these patients. And it's not just the ADA. The Centers for Medicare and Medicaid Services also describes a DDS or a DMD as a physician. And again, another important distinction, because it allows you to communicate with your other physician peers when it comes to managing patients with sleep disorders. The other important factor that the ADA has done is that they've defined your scope of practice. And again, this has been adopted by the majority of the dental boards in America, if not all of them. And important for you to note within your scope of practice is that you are not just responsible for the oral cavity, but you're also responsible for the adjunctive and associated structures and their impact on the entire human body. And to understand this, here is the anatomy that is within the scope of your practice. Not only are you looking at the oral cavity, but you're also responsible for everything else that you see there, the soft tissue and the hard tissue that impact the airway. And one of the things that I want you to take away today is that when we talk about the upper airway, we talk about an airway that begins at the tip of your nose and it travels through your nasopharyngeal passage all the way down to the back of your throat, in simple terms, right? So if you look at this diagram, everything that you see in pink, the soft tissue, is your area of responsibility. And in particular, as we deal with patients that suffer from sleep disorders. So regardless of your experience, whether you have been treating patients with sleep disorders already or you're thinking about doing it, what I'm going to do for you today is bring you up to speed. What has been happening in the last 5 years? Because there's been a growing momentum of attention on the subject of sleep disorders, and in particular, dental sleep medicine. So what you should know is that the general population at large has become more aware of their sleeping habits. Not only are they seeing news articles that show that train operators, for example, were later found to be sleep apneics as a result of a train accident, but they themselves are feeling tired and they're looking for answers. So much so that Arianna Huffington published a New York Times bestseller on the subject of sleep disorders. So the general population is interested to know. The interest is so high that we have a multi-billion-dollar industry in the wearable device industry following and monitoring the way that we sleep at night. So again, this is to show that the general population has an interest in how they sleep. And more importantly for us in the dental community is understanding that the American Dental Association published an 11-point position statement back in October of 2017. And within that position statement, one of the recommendations from the ADA is that every dental office should be actively screening for patients that suffer from sleep disorders and to treat those patients when indicated with an oral device. Again, we'll talk a little bit more about this, but this is important because the ADA is now establishing the standard of care when it comes to patients with sleep disorders. And as recent as late August, as of August 24, 2018, the ADA hosted their very first Children's Airway Health Conference because treating and managing patients with sleep disorders, we have standardized protocols for adults, but we don't have standardized protocols for children yet. In fact, as I mentioned, I'm part of the task force that is developing the standardized screening protocols, and we haven't even published that yet because it takes a while to develop some of these standardized processes, right? So this industry is still very nascent in many ways. But here we have the American College of Prosthodontists issuing another position statement describing the role of oral devices to manage patients with sleep disorders. And more recently, the American Association of Orthodontists back in 2019, March of 2019, issued their 10-point position statement on obstructive sleep apnea and orthodontics. So organized dentistry is recognizing the need for dentistry to actively screen and treat these patients. Here we have the World Dental Federation also publishing a position statement. And this is in response to research that was published back in May of 2018, when a team of some of the most widely recognized researchers published the prevalence, the global prevalence of patients with this condition. And the results of the study is that we have approximately 1 billion people that suffer from sleep disorders, and in particular sleep apnea. And that number is considered an understated number because we fear that the numbers are much greater than that. So as you could tell, we have a large number of people that need help. We do not have enough providers that could actively help these people. And as you will learn today, dentistry plays an important and vital role, not just in identifying these patients, but actively being able to solve some of the pain that these patients are suffering. And I have to bring you up to speed because dental sleep medicine, the science of it, has been around since the mid-80s. And the science of sleep medicine as a whole began in the early 70s. So in relative terms, we're still dealing with a very nascent and growing industry. But the standard of care has begun to shift, right? The current model has been predominantly focused on providing a patient with a sleep appliance and hoping that the appliance is going to work on that patient if they snore or have sleep apnea, right? So the current model is largely focused on a widget. What do we do with this widget? So there's little collaboration with other medical providers, and there's minimal consideration for the fact that these patients will have to wear these devices long-term care. So the shift in the standard of care is that we are now focused on successful patient outcomes, and we got to look at these patients from a holistic treatment plan perspective. We have to consider the restorative and the orthodontic treatments that the patients may need as part of the evaluation and treatment plan when it comes to sleep disorders. So that requires a comprehensive analysis of the airway, the dentition, the craniofacial complex, and the joints if you're going to successfully manage these patients long-term. And it definitely requires the collaboration of other physicians because, for example, the sleep appliance can't do anything when it comes to hypertension, as an example. So more importantly, however, is the fact that patients that wear sleep appliances are no different than patients that wear a CPAP. They will have to wear these devices more than likely for the rest of their lives unless they undergo reversal techniques that may require surgery, as an example. And the other thing that you should be aware of is that the, my screen just kind of clicked there. Can you see me? Hello?
Sal, yes, we can. We can still see you. You're still on. We're seeing the slide dentistry and sleep.
Okay, I apologize.
No
So,
problem.
Yeah, so getting back to the relationship of, dentistry and sleep is to understand the intimate connection between malocclusions and airway deficiencies. When you're looking at a patient with a malocclusion, is there a possibility that that patient may have an airway deficiency? And to help you understand that, I'm going to introduce you to this neurologist, Dr. Christian Guilleminault. Dr. Guilleminault is considered one of the co-fathers or co-founders of the science of sleep medicine when he began to study and do research at Stanford University. And Stanford is considered a mecca when it comes to the science of sleep medicine. And why Dr. Guilleminault is important to you is because Dr. Guilleminault was a prolific researcher. He had published up to his death, he just recently passed away, unfortunately, his 786th article on the subject of sleep disorders. And to you, the importance of that research is that the majority of his research, and especially in the last decade, focused on the collaboration of the dental component. And to help you understand that, here I have a research paper that Dr. Gimeno and other researchers published back in 1997, which is a predictive morphometric model to identify patients with obstructive sleep apnea. And what it is basically is a formula, an algebraic formula that Dr. Gimeno came up with. And what's important to you here is that the 6 variables in that formula, 4 are specific to dental comorbidities. What is the height of the palate? What is the maxillary intermolar distance? And what is the mandibular intermolar distance? And lastly, what is the overjet discrepancy? These 4 dental comorbidities added with the patient's neck circumference and the body mass index represented a highly predictive understanding if the patient may or may not have sleep apnea. Today, we don't need this formula because we have equipment that can more accurately provide us with that information. But it goes to show you that for many years now, the medical community has known of the importance of the dental component when it comes to airway deficiencies. And there's so many other papers. Here I have another example from Dr. Gimeno showing that pediatric obstructive sleep apnea and the critical role of orofacial growth. And the conclusion is that pediatric OSA in non-obese children is a disorder of the orofacial growth. And here I have another paper that shows that a short lingual frenulum that is left untreated at birth could be associated with obstructive sleep apnea syndrome at later age. So just imagine that if a patient is tongue-tied at birth, the not releasing the tongue-tied could have tremendous impact in that patient's life for the rest of their lives. And here we have another document that shows the orofacial motor functions in pediatric obstructive sleep apnea could be addressed through myofunctional therapy, as an example. And here is the link between sleep bruxism and sleep disorder breathing and temporal mandibular disorders. This is an important article or research paper because it shows the connection of bruxism, right? Traditionally, most dental offices are prescribing a night guard, not realizing that the night guard could potentially be contraindicated. Because if a patient is bruxing, there's a good likelihood that the reason that they're bruxing is because they're trying to maintain that airway open. As a result of now introducing the night guard could potentially prevent the patient from having that defensive mechanism work properly. So the actual protocol today, if you see a patient that bruxes, is that you first have to rule out if the patient may suffer from a sleep disorder, as an example. And here we have another paper showing that rapid maxillary expansion for pediatric patients is a successful intervention in many patients. And here we have another document that shows the long-term effect of rapid maxillary expansion in these patients. And here we have another document that shows the different types of expansions that could be done on patients regardless of their age. So if you have, for instance, a patient between the ages of 6 to 12, you could use a traditional rapid paddle expander, but on adult patients, you could use temporary anchorage devices that are implanted to create, let's say, a 10-millimeter diastema, and then you close the patient with clear aligners or with braces. Or later on, as the patient gets older, you could do what is known as a SARPE, which is a surgically assisted rapid paddle expansion. So again, this is just to show you that there's a lot of medical and dental research confirming and validating that dentistry plays an important role, not just in identifying, but doing something about this problem. And why it's so important is going back to the research where I said that we have an approximate 1 billion people that suffer from sleep apnea. So let's look at the prevalency here in America. And to help you understand that, here's a map that was published by the Centers of Disease Control back in 2009, which is a result of a 10-year surveillance study in America to show the patterns of people that suffer from insufficient sleep. And the conclusion of that study is representative of the fact that in certain states, such as California, where you see a white colored state, it represents that at least 21.8% of the adult population suffers from insufficient sleep. And in some of the other states, the darker colored states, it could be as high as 37%. So at the very minimum, you should understand that 20% of the adults in your practice need immediate attention, because there's a good likelihood that these individuals are suffering from an airway deficiency that needs to be addressed. But why this is important is better understood by looking at these maps that are next to each other. And on the right, you see the heart disease death rates in America. The pattern is very similar to the pattern of those with insufficient sleep. And the same is true when you look at patients that have stroke as a result of their death. And the same is true for patients that suffer from type 2 diabetes, right? The patterns are very similar. And that's because we understand in the medical community that if you leave obstructive sleep apnea untreated, there's a good likelihood that these patients will suffer from these other medical comorbidities. Again, from diabetes, hypertension, stroke, daytime drowsiness, and early death, amongst many others. So sleep disorders, in summary, is a condition that impacts millions of Americans today. And the Centers for Disease Control considers sleep disorders an epidemic here in America, and around the world, this is considered a pandemic. There are over 100 different types of sleep disorders that range from sleeping difficulties to excessive tiredness. So it's not one specific problem. There's a multitude of them. But when it comes to the subject of sleep-related breathing disorders, the three primary conditions are snoring, upper airway resistance syndrome, and obstructive sleep apnea. And this is where you come in, Doc, because dentistry plays a vital role, and it's within your scope of practice to address these three primary conditions that people suffer from. And when it comes to snoring, we traditionally think of snoring as a sign of a potential sleep disorder, but the reality is that medical research shows that snoring as a standalone condition, independent of sleep apnea or other sleep disorders, could be the cause of carotid artery atherosclerosis. Basically, the plaque buildup in the arterial wall that could occur as the vibration of that the patients suffer in a compromised airway, right? So to better understand the airway, I'm going to show you this other diagram to help you understand once again that when we talk about the upper airway, we talk about that entire region that begins at the entrance of the nasal cavity, right? The nostrils, and it travels through the nasopharyngeal space, down through the uvula, which is considered the velopharynx, behind the tongue, the oropharyngeal space, and then down into the vocal fold. That entire region is what we consider the upper airway. And when we talk about patients with breathing disorders that could represent a sleep problem at night, we talk about issues within that region. And to better understand this, I'm going to introduce you to Uga. Uga is the mascot for the University of Georgia. And you're looking at Uga back in early 50s, all the way up to current times. And as you can see, Uga has become cuter to some of you, but in reality, the dog is becoming more diseased, right? So the modern bulldog looks like this dog at the front, but the ideal bulldog should be looking like the dog on the right. And the differences between the two dogs is that the canine on the left as you could appreciate on this sagittal view of the cone beam, has a very narrow airway, whereas the ideal bulldog has a much more open airway, as you could see behind the tongue, right? And you could tell there on the image on the far right for each one of the dogs. So for those of you, again, that are considering sleep or doing dental sleep medicine, why should you do this today? Well, first of all, you should know that this is the fastest growing modality in dentistry. And it is not physically demanding. It requires you to think outside of the box because you have to troubleshoot the patient and understand what may be causing their airway deficiency. But from a physical perspective, this is not drill and fill. You're using functional devices, and it's really easy on your body, unlike most of your traditional dentistry. And you should be aware, as I mentioned already, is that the majority of patients that suffer from these conditions remain undiagnosed. Over 80% of patients have not been diagnosed and remain untreated. And as I said already, we do not have enough clinicians today that could tackle this problem here in the US or around the world. And every single commercial insurance payer covers the treatment of patients with sleep disorders using oral devices. And we'll talk about that in our next session, by the way, in more detail. And this is also essential therapy that improves the quality of life of your patients, especially today when we're dealing with what's going on with the COVID situation. This is not elective therapy. This is a necessary therapy, and that will allow patients to live and breathe better. And it could potentially save lives, as I mentioned. And going back to the subject of the coronavirus, as you're going to learn here shortly, when it comes to airway deficiencies, and when we talk about coronavirus, we're actually talking about the same stuff. Here we have a research paper that was published by the American Heart Association that shows the intimate connection, again, between sleep apnea and cardiovascular disease. And here we have another article that shows the connection between obesity and obstructive sleep apnea. And yet another one that shows the connection between sleep disorder breathing and COPD, and the connection of sleep apnea with hypertension, chronic kidney disease, and how the two are interconnected because they have common pathologies. And why this is important is because we're dealing with the coronavirus today, right? And while I'm not going to make this whole topic about the coronavirus because there's enough information out there, as of today, we have 18.3 million cases of patients that have been diagnosed with the COVID, and close to 700,000 people have been killed as a result of the coronavirus. And why we want to talk about coronavirus when we talk about airway deficiencies is because the comorbidities, the underlying conditions are very similar. Hypertension, obesity, cardiovascular disease, chronic lung disease, renal disease, and asthma are all interconnected with sleep disorders and airway deficiencies. Right, in this case, you could see hypertension is leading the pack, where we have 56% of patients with COVID are hypertensive, right? COVID enters the body through the upper airway, right? And it travels down and attaches itself to the lung. So COVID and sleep disorders are very similar, right? COVID-19 is a pandemic. I have to update my slide. We're beyond 9 million cases now, as you saw earlier. It compromises the airway, as we discussed, and it has all of these other medical comorbidities associated with it. But sleep apnea, as you could tell, is also a pandemic. And in the case of sleep apnea, we're dealing with close to 1 billion people, right? Also compromised airway and similar underlying conditions. But there's another thing you should know about COVID when it comes to sleep apnea. The aerolization of COVID-19 by the use of a CPAP machine could lead to the spread of the virus. And this is important because the American Dental Sleep Medicine Association, the American Academy of Dental Sleep Medicine published recently a position statement stating that the use of oral devices should be the first-line therapy today to treat any patients with obstructive sleep apnea, because the gold standard CPAP is contraindicated as a result of the aerolization that I discussed earlier. Moreover, the American Academy of Dental Sleep Medicine published another article saying that oral appliance therapy should also be reimbursed as first-line therapy for patients with obstructive sleep apnea, given the situation that we're dealing with. And again, why this is important for you is highlighted by the position statement from the American Dental Association, because dentists are the only healthcare providers with the knowledge and the expertise to provide oral appliance therapy to patients that suffer from sleep-related breathing disorders. And the medical community is behind you, Doc. So as you consider other physicians, other associations also promote the use of oral devices. Here we have the American Thoracic Society promoting the use of oral devices to treat patients with sleep disorders. Once again, we have the American Heart Association promoting the use of oral devices. And in fact, later on, it states in that same paper that patients prefer the use of oral devices over their CPAP. And who wouldn't, right? Unless you want to be Darth Vader or you want to be a fighter pilot, I don't know why you would prefer the use of a CPAP when the oral device would be a more comfortable, convenient device to use. And going back to what I said earlier, then, if you put your dental hat back on, think of this topic, right? Patients with malocclusions may be suffering from sleep disorders. When your traditional patient comes and asks you to correct their minor tooth crowding, you might have to dig deeper to understand why is that patient having the minor tooth crowding to begin with. So as you look to identify patients with these conditions, you want to look for vaulted palates and narrow arches, as I explained to you about Becky Wade and her condition, as the paper shows from Dr. Gimeno, how vaulted palates is one of the markers to identify patients with sleep disorders, right? When you see overcrowding of the arches, or when you see bruxism or abfractions, these are all signs of someone that is struggling to breathe properly. Scalloped tongues is another sign, right? And here you could see other samples, right? When you look at the patients that were presenting to the practice with some tooth crowding, some cross bites, and some narrow bites on occlusal wear, you could see the before and afters, how the arches are better expanded. And it's, in this case, we don't even need to expand in the traditional sense of a rapid paddle expander, but when we correct, when we upright teeth, you're creating more room so that the tongue fits properly, because oftentimes the tongue is one of the primary culprits that is blocking the airway, right? And when you then look at identifying your patients, the low-hanging fruit for your office is any patient that tells you that they wear and use a CPAP should be a patient that you should consider offering a sleep appliance. Patients that feel tired throughout the day, no matter how many hours they sleep, like Becky Wade, would be an example of a patient that needs a sleep study and considered for a sleep appliance. Patients that tell you that they snore at night, or their bed partner tells you, hey, my husband snores. These are all types of patients that you can immediately start investigating and treating. As I mentioned already, night guard users, recall every single one of your patients with night guards, and let's evaluate them to see if they probably suffer from sleep disorders. Patients where you previously prescribed the clear aligner therapy or brackets and wires to correct our malocclusions are also candidates for potential airway evaluations. So let's tie this up, right? We've talked about the prevalence of the condition. We're talking about how can we quickly identify possible patients that need attention, and how do you do that with cone beam technology? Why should you consider cone beam when it comes to this segment of the population? So to highlight the benefits of the use of cone beam, I'm going to show you a case example where we have a young female that presented to the practice, and on screening, she scored at high risk of being a patient that suffers from sleep apnea. And as you could see here, we're talking about a young female that is within normal limits, right? Body height and body weight are within a BMI that's within normal limits. But can you see the check marks that the dental clinician checked off? This patient has a constricted maxillary arch, a retrognathic mandible, a high vaulted palate, occlusal wear. This classification 4 for a Mallampati. If you don't know what a Mallampati is, it's a quick way to ascertain how much of the airway can you visualize when you have the patient open their mouth. And in this case, the patient has a highly constricted airway, so you can't see back there. And she also has a family history of sleep disorders, cardiovascular disease, type 2 diabetes. Again, she's a walking billboard for a patient with sleep disorders. And in addition, the doctor says that the patient has anterior occlusal wear, crossbite, and a tori. Again, all signs of someone that has a potential sleep disorder. Additional notes for this patient is that the patient was previously diagnosed with sleep apnea, and the therapy that was provided for her was the use of a typical UV light that is used for patients that have vitamin D deficiency. As you will see, not this patient, because the dentist in this case noted that the patient could barely open their mouth, which is indicative of a joint problem. She has a very petite facial structure, and the patient appears to be medicated even though she's never taken any medications. This is what the patient looks like, and you could see her physical struggle with her airway deficiency. And we haven't even tested the patient for a sleep problem, but we could already document the physical signs and the clinical history that the patient suffers from an airway deficiency. Unfortunately, the practice only had a panel available, and yes, we could see the airway, but unfortunately, it's not enough data for us to truly appreciate to what degree the airway is compromised and how is the soft and hard tissue and the joint impacting the condition of that airway. So when we conducted the sleep study, our physicians noted that the patient only scored within normal limits, 1 apneic event per hour and 2 on the second night, which are all within normal limits. All bells went off because they knew something else was going on. And in this case, we note that the patient respiratory distress index, which is an index that documents other phenomena that is causing the patient to have fragmented sleep, is beyond the normal limit, right? 5 or above is not normal. We also note that the patient entered the rapid eye movement stage of sleep only 4% of the time, when for most of us, normal time range is between 20 to 25% of the time. So that explains probably why she's tired throughout the day. The patient is a snorer, but a very light snorer. She snored the entire time, very lightly. And more importantly, as you could see here, is that her pulse rate and her arousal were off the roof. You know, she was marking 96 arousals per hour when someone her age should be between 10 to 15. So certainly something is keeping this individual awake in the middle of the night. And indeed, the diagnosis for this patient was upper airway resistance syndrome. But if we would have had a combing of the patient preemptively, we would have noted that the patient's airway at the oropharynx, which is located behind the tongue, what you're seeing there colorized is the back of the tongue and behind the uvula, the soft tissue, that is within normal limits. And if you didn't have this visibility and your protocol is to prescribe a sleep appliance that moves the mandible forward, that would be contraindicated on this patient, because this patient's condition is largely impacted by the fact that her nasal pharynx is compromised. So to highlight why you need this kind of visibility, here I have another case example to show you where this individual also has a long history of sleep disorders. And I know that for some of you, looking at this anatomy in 3 dimensions may be new, but on the left, you're looking at a sagittal view of the patient's head, and you could see the airway, which is that negative space in black. And you could see the roof of the mouth, the palate, right? I don't know, can you see my pointer, right? Here's the roof of the mouth. Here is the uvula, and here's the tongue interconnected to each other. And this is the pharyngeal space, so very narrow. And here you could appreciate a colorized version of that sagittal view of the patient. And down here, you could appreciate the upper and lower arches as you're looking at the patient at the front of the patient. And you could see the high vaulted palate, and you could appreciate how the roof of the mouth is also the floor of the nasal cavity. So if you have a high vaulted palate, there's a likelihood that the nasal passage will be impacted, as it is in this case. So here we see that the airway is less developed on one side. That's important to us to understand from a joint management perspective. And through the use of the DICOM information, we're able to do what we call a virtual airway endoscopy to appreciate how inflamed that airway is. And in fact, as you look here, you could see that the dark area is the area that the patient is breathing in with, but everything in white here should also be in black, right? So instead of having a garden hose to breathe with, this patient has a straw to breathe with. And here you're looking at the nasal cavity, and it helps us understand that the nostrils are compromised as well. So this patient is prescribed the use of a spray and some nasal cones to expand the nasal cavity as well. And here we could appreciate once again how the narrow palate impacts the inferior turbinate, and how the use of a custom device would be ideal for this patient, but also referring the patient out to an ENT to collaborate and co-manage this patient is going to be important, right? You can't be a lone ranger when it comes to dealing with these type of patients, because as you could see, the airway could be impacted anywhere. More importantly for this patient is that the patient has developed what we call a military neck, which is a stiffening of the neck as a protective mechanism because the airway is so compromised. So this is the only way that the body could ensure that while the patient is awake or the patient is asleep, that they could breathe properly. So when we consider managing patients with sleep disorders, it is our recommendation that you either have a cone beam machine that could take an image as the one that you saw, or that you refer the patient to an imaging center that could capture this kind of an image. Because a cone beam is going to allow you to look at the soft and the hard tissue and the condition of the joints when it comes to managing these kind of patients. And to do so, our recommendation is to use a cone beam that is a low dosage cone beam machine that could give you a very relatively quick scan, and that it has the appropriate field of view. And this is important because there are a lot of cone beam manufacturers in the industry that incorrectly state that their device is able to capture the airway, when in fact, their device is only able to capture a portion of the airway, as you're going to understand in a few minutes here. But not only are you able to evaluate the airway in detail, but a properly sized field of view allows you to do some of the other comprehensive therapies that are necessary for these type of patients, from orthodontic intervention, as I mentioned already, TMJ evaluation, airway management, implants, and surgery, right? So to understand why we talk about the appropriate field of view, let's look at the results of a study that was conducted by the US Army and Navy, basically the Department of Defense, when they're evaluating the adult population that they need to outfit with helmets. And you'll notice that in the 95 percentile of adult males, the measurement of the ramus to ramus in diameter is 15.2 0.5 centimeters. So when we talk about a combing machine that could capture the joint properly as you're evaluating the airway, we want to ensure that at the very minimum, you have the ability to capture 15 centimeters wide in diameter. And to appreciate this, here we have two images, a field of view that is 16 by 10 and a field of view that is 15 by 15. And you'll notice that on the 16 by 10, you'll get an opportunity to certainly see the entire region of interest as you would with the 15 by 15. And ideally, you want to have an opportunity to look at that entire area of interest, because like in this case, you're able to see that we could do a baseline cone beam scan and a cone beam scan post-appliance delivery, and you could quickly ascertain what the appliance is doing to the patient's airway and what the appliance is doing to the patient's joint, as an example, right? And it's also a great education tool to help the patient understand the immediate benefit that the patient will enjoy when wearing the device. So as a summary, the appropriate field of view when it comes to airway analysis is a 15 centimeter wide field of view, and at minimum on the height of 13 centimeters. However, we recommend an even higher height of 15 at the very minimum. So at this point, Jim and Paul, I'm going to turn it over to you to help us appreciate how easy it is to capture these areas of interest on patients that suffer from sleep disorders, because I've only been showing you at the moment static images of what the airway looks like. But I think it's imperative for all of you to appreciate not only how easy it is to collect this data and analyze it, but also why you want to be able to do this from a clinical perspective and also from a patient education perspective. So with that,
Sure.
Paul?
No, we agree 100%. Yeah, it's educating the patients not only with graphs and charts, but actually showing them the data of their actual scan themselves for that. So we do have our live demo here. Paul's going to bring up a scan, and Paul, I believe this is either a 15 by 15 or a 17 by 15 scan.
Yeah, so what I have here is I do have a 15 by 15 scan here in the Vatech software, so I'll just go ahead and bring that up here. I just want to highlight a couple of the tools here, and Sal, as I'm going through, please feel free to jump in here. So the first thing is I just want to focus on visualizing that virtual airway. So on my screen here, on the sagittal view, we're going to trace that airway. So to my left, if I go ahead and click on measure airway on the left, it'll automatically bring up this sagittal view. And what I'm going to do here is just we pick 2 points. I'm going to start in the back portion of the hard palate, and we draw this line down past the epiglottis there, and it's going to now render that airway. So I'm going to go ahead and pull that up here. You can see on the 3D, it shows it very well in the 3D. I'm going to go ahead and expand that window. We can take our opacity down if I want to just have that airway there by itself. We can see it measures the total volume and the most constricted area. So just, we have a bunch of different views and how you can view it in here. If I right click on my airway, we're gonna get an option to measure it. So basically, when I open it up, it's going to have the most constricted part of the airway there, and I can scroll up and down it to get my millimeter squared measurement up and down that airway.
Yeah, and what I would add to what you're doing here, Paul, is to show that the point that appears to be most constricted in this particular patient appears to be in what we call the velopharynx, which is the region just behind the soft tissue, or the soft palate in particular. And for instance, this type of a patient is more than likely a heavy snorer, and the combination of his tongue and the soft tissue or or the soft palate in particular, are causing this patient to not just have the snoring events, but more than likely the apneic events that the patient is suffering from. So if you had this presentation in front of the patient, you could guide the patient to explain to them, number one, why they snore, right? Why your wife keeps on saying that you're a loud snorer and you don't know anything about it, right? Because most of us that snore, we're not aware of it. And there's a good reason behind that. You know, our body is supposed to be at its most relaxed state, and we're somewhat in a trance. In fact, we're supposed to be immobile for the most part, right? Our limbs are not supposed to express themselves because we could potentially hurt ourselves or our loved ones. And that's another neurological problem, you know, one of the 100 different types of sleep disorders I discussed earlier. But when it comes to sleep apnea, as you're educating the patient, and as you could see Paul transitioning from the hard tissue to the soft tissue, this is a great way to help educate the patient and understand what's going on with them, and to, more importantly, take ownership of their disease, right? Most people will try to be dismissive, and especially when it comes to males, that they have a problem. So this is a way to help them take ownership of that problem. So go ahead, Paul, if you don't mind, maybe even showing how you could easily, I mean, this is amazing, right? How quickly you could go between soft tissue and hard tissue, visualize the condition of the airway. But can you also show, if you don't mind, the joint for this patient, and how quickly you could also look at that? As you could tell, you know, the beauty of the software is that it's pre-intuitive, and you could quickly just move through the different areas of the body that you want to highlight for your patients.
So I was just going to highlight the section tab. Sal, do you want me to go into here?
Look.
This one's just going to take us, you know, right from the tip of the nose here. We can visualize that right through on our section tab. So.
Yeah, and actually, if I may add a little bit here, you could see again the collapsibility of the nostrils in this case, right? One side is more collapsed than the other as you're traveling through there. And imagine being able to share this image with your colleague, the ENT, to help co-manage the patient's condition. And again, the beauty of being able to travel through that entire pharyngeal space is that you could help identify areas of concern that either the patient needs to be aware of, or even as you collaborate with your other clinician physician, how you could address that patient.
For sure. And so in the first case, we looked at the oral pharynx. Now we're in the nasal pharynx. You know,
right.
Two separate areas, and then working with the ENTs and conveying to the patients there.
Yep. Okay.
Using that tool.
Yeah. So next, let's take a look at the negative space in the sinus area. Jim, do you want to kind of mention that a little bit?
Sure. Well, Sal, you talked about looking at the hard palate for like palatal expanders and things. So maybe Paul will we'll look at our volume tool. So let's go ahead and go over to our volume tool,
which is right here on our toolbar.
Correct. And now we can expand that out.
So we have
Sal, are you having offices using this with palatal expanders, or in this case, I guess, Paul, we're going to go ahead and do the oral pharynx there for another view. And take that out to the tip of the nose there. Or yeah, there you go. Now we can go ahead. Yeah.
Yep.
And we get that visualization.
Right about there.
So it's going to be another way we can convey deviated septums, looking at the inferior nasal concha, the nasal passages. Sal, what else are you looking at or you're showing for our clinicians?
Yeah, no, exactly what you mentioned there, Jim. You know, the ability to quickly look at the nasal passage and understand, obstacles that are preventing the patient from breathing properly and maybe encouraging mouth breathing, right? Mouth breathing is a complete topic all on its own. Up to 54% of children are mouth breathers, as an example. And why this is important is that when we breathe through our mouth, we bypass our natural protective mechanism, which is housed in the nasal cavity. So as you're appreciating the colorization here that Paul is showing you, is that without much understanding of the anatomy, and this is especially true for patients, you could show them, oh look, right here on the left side, look, your sinus is constricted, and you could quickly do that by showcasing it using this tool that Paul just showed you.
Yep.
For sure. Paul, let's take that volume tool down below the hard palate.
Okay,
So
let me
go
just
ahead.
I'll do
There you
another
go.
one here.
There you go.
So let me
And
actually pull this forward here. Okay.
And Sal, how are we using this, or what is your experience with this as far as palatal expanders and measuring that high palate? This could be used as a before and after, or to look at that volume in that area.
Right. So it also has a multifunction, but again, if we go back to the subject of educating the patient, it helps us highlight, number one, that the palate is compromised, right? It's narrow, it's vaulted. And secondly, when patients are not naturally placing their tongue, the tip of their tongue at the roof of the mouth, for example, we could also highlight how the patient may need some mouth-functional therapy to help them understand how to properly breathe by maintaining proper lip closure and maintaining that tongue at the tip of the mouth. And also it helps us understand how the soft tissue, in this case, it's slightly elongated, is connected, in this case, to the tongue. Now, I don't mean attached, but just, they're both touching, and how at night when these two the soft tissue and the muscle, the tongue muscle collapse, could be creating, again, an obstruction of that airway, and could explain why the patient feels so tired throughout the day, why the patient is snoring, or why the patient is waking up in the middle of the night gasping for air, right? Because these are all indications for someone that may be suffering from sleep apnea. But not only, is the visualization that you're doing important from an education perspective, but I know other tools that you have measurement tools, right? So you could do an intermolar distance measurement of the palate to show you that the palate is compromised, right? In some patients, in most patients, in fact, it should be between, let's say, 38 millimeters to 42 millimeters. But in a lot of patients, you'll find that suffer from airway deficiencies. We have patients that have less than 38 to 42 millimeters of ideal arch width. So again, this is a way that we commonly evaluate airways and how we utilize the software to not just determine the clinical necessities of the patient, but also educate the patient on why they suffer from the condition, right? Because your job as a clinician is to help the patient become educated and take ownership of their disease.
Right, and throughout this process, then we can take those screenshots, and if we are getting oral appliances, we have the before and the after screenshots, or basically our progress for when we do our treatment and our therapy there.
Right.
Yep, which are on here. Stored right in the software in there. Yep.
Yep.
Great.
So I think a lot of this is going to be leading up to what we're bringing on for our next session with Dr. Atai. Sal, do we want to go back to you for the presentation, continue on with your slide deck, or was it best to just kind of talk about this and go to ours?
Yeah, I only had a few more slides to present, in particular how to obtain your CE later on. So
Right.
maybe move forward, and then I'll finish off with that information.
Sure. Well, let's do this. Paul, let's go ahead and come over to my screen over here, and let's talk a little bit about maybe some patient positioning specific to our CBCT, which we will talk more about in our next session. But what I'd like to do is talk about positioning for our CBCT. And what we've done is we've got our 3D airway capture with our chin rest here and our chin cup, so we can get them in a centric occlusion or our patients in a natural bite to get that natural head position there. Yep. Here's another screen kind of outlining some of the tools we have, but also where you can get your visualization of the chin cup there, and then all the way positioned in that natural bite, showing that soft tissue outline, the airway, and your outline through there. So we have a lot of training and education resources on this. I believe, Paul, we've been covering this also on our Friday series of Fast Track Fridays, of going through specific positioning for CBCT and airway capture, and then how to convey this message to the patients through there.
Right, and a lot of it specific per which device you may have too. So.
Correct. All right, Paul, do we have any questions coming up? Look over here on our question list. I don't have anything really coming up from the audience there. If anyone has any questions, go ahead and feel free to ask now. Sal, I think you covered like the screening process as we went through your presentation. What we're going to be visiting back in September with Dr. Atai, bringing a clinician on who has implemented this in their practice. So I think you've kind of set the foundation, and now we can roll into providing this to our patients if we are currently doing that, seeing how a clinician is presenting this, not only to his patients, but also the business world of it too, a little bit through there, a little bit of billing and kind of going through this. So I think you can talk better on that than I can for next time.
Yes, yeah, indeed. So what's coming up is, how do you implement a successful dental sleep medicine program in your office where you could generate the appropriate revenue to provide your patients with the ongoing treatment that's necessary and that is compliant with the practice parameters as issued by the American Academy of Sleep Medicine. So we will dive into that topic in our next session, and we'll show examples of the types of medical coverage and reimbursement that you could expect if you are billing medically for these treatments in your local community.
Correct. Yeah. All right. Sally, do you want to show your screen for that CE? And we do have a couple questions. While you're doing that, let's go ahead and, Paul, I think we got a couple questions on there.
Yeah.
You want to go through those?
Yeah, let me pull these up. What do you do? Jessica's asking, what do you do when someone you are trying to position has high shoulders?
So I think, Paul, you and I can talk about that. It's a matter of, a lot of, if we have these patients that are dealing with sleep problems, or maybe they're bigger patients, a lot of times I'll just sit them in a chair just like I am now and have them relax their shoulders down. Is a really easy way to do that. They can sit in there and relax the shoulders down, or on our device, just have them hold with their palms facing up, and that's going to drop the shoulders down. That's the real simple answer. Jessica, I would say check out our Fast Track Friday series to talk about more about that. Yeah. We have another question by Raymond. Will info presented by Sal be available via web, PDF, etc.? This will be recorded and it will be on the Vatech Education website, the Vatech website, under the Customer Learning Center. You will also get a link afterwards directly to that.
Yeah, and if I may also add to that, which was part of my slide here, when you request your CE, if you're interested, you could also request a white paper that gives you a detailed understanding of why you want to consider the proper field of view when it comes to treating patients with sleep disorders. So this is an adjunctive document that you could utilize in addition to the recording that you'll be watching. It comes with tons of references that provide you with the justification as to why not only should you be identifying these patients, but more importantly, what structures should you be evaluating when it comes to patients with sleep disorders. So I just thought I would add that to that question there.
Right. Paul, you want to check some of the other questions there?
Yeah, Victor's asking how does sleep, and I apologize if I mispronounce this, how does sleep apnea CPAP cause aerosolization for COVID?
Yeah, so what happens is that because a lot of the patients are either wearing a facial mask or they're wearing nasal cannulas, there's leakage of the air because CPAP is an acronym that means continuous positive airway pressure. So these devices are forcibly pushing the soft tissue out of the way so that the patients can breathe properly. And again, I want to make sure that everyone understands CPAP is considered a gold standard. However, during this current crisis, the CPAP has a contraindication if you're utilizing the device at home, because while the air is forcibly being pushed, if the patient is compromised, that COVID is going to be spread within the room or the area that the patient is sleeping at. And for that reason, it's at this point considered a potential contraindication. And you should be aware again that a lot of patients with breathing disorders, and in particular sleep apnea, suffer from a lot of the underlying factors that we know could compromise them to the COVID virus. So that's why it's a sensitive situation and why these patients should consider the use of an oral device that, obviously is not blowing any air and will help them not only sleep better, breathe better, but not compromise their family members through the use of that therapy.
Great. Here's another one from Cameron. Does oropharynx change based on tongue position?
Does the oropharyngeal space? Yes, it does. So, the traditional thought, and in many ways it's correct, right? The tongue is attached to the mandible, right? So if you have a class 2 retronaphnic patient, and this is why, again, the medical community has done a lot of research when it comes to the subject of airway deficiencies and the dental classification of the patient, for example, right? Because class 2 patients will tend to be retronaphnic. And what that means then is that the tongue that is attached to the mandible is already compromising the airway on these patients. And if you position the mandible forward on these patients, you'll have an opportunity to clear the airway. In fact, if I may just show the slide, going back to this comparison, right, where we took a patient at baseline, and here comparing it to the patient wearing the device, you could see that this patient is approximately 2 to 3 millimeters from centric occlusion and has a vertical opening of about 3 to 4 millimeters. And that minor millimeter advancement is causing the tongue to clear that airway. So there's a mechanical component to dealing patients with these conditions because, as I mentioned before, the tongue could be one of the primary culprits that's causing the patient to have a complete blockage of that airway, which is what we consider an apneic event. And by simply moving the mandible forward, we would have an opportunity to clear that obstruction. The challenge is that it's not as simple as just moving the mandible forward, as I showed in the other case examples, because you can't just focus on what's going on in the oropharyngeal space. You also have to take into consideration what the nasal passage looks like, right? Because, for example, if the patient is a mouth breather and you're trying to move the mandible forward And the majority of the appliances in the market are dual arch devices that engage with each other to move the mandible forward. If the patient's a mouth breather, there's no activation of that mandibular repositioning, right? As an example. And again, this is why the evaluation of the patient's condition, the craniofacial complex, the soft tissue are important in your consideration for the appropriate treatment of that patient. In our next session, we're going to dive into more of that detail. So I want to table some of it so that you could get a better understanding of it as we show you case after case as to when it's appropriate to move the mandible forward and when it's appropriate to do a different type of therapy considering what's going on with that patient. And the last thing I'm going to say here is that, you know, the concept traditionally in dental sleep medicine is that you just arbitrarily move the mandible out. You know, you measure the patient's maximum protrusion, and then you bring them back 60 to 70% as your starting point, which there are studies today that show that that starting point is usually too far out for the patient. And there's other studies that were done by Dr. Gimeno, the neurologist that I talked about earlier, that show that 1 millimeter of intraoral cavity space improvement represent a 2.6% increase in airway volume. So you don't really have to move the mandible out far to get the airway to open up, as you could see on the image that you're looking at now. So I know that was a long answer, and I'm hoping it addressed the question.
Okay, perfect. One more question here from Brian's asking, is it worth the radiation exposure for something that may not translate to the patient lying down when the soft tissue collapses during sleep?
Well, yes, and that's in fact a very good question because it's a question that we hear often, right? What's the utilization of cone beam imaging if the patient is awake and not asleep when we could better understand how the airway is compromised? So I think to answer that question, again, I'm going to go back to this image, right? Because even though the patient is standing upright when this image was captured, we could appreciate how the soft tissue and the hard tissue, and in this static image, you don't see the extensive evaluation that was done on the patient, because not only are we looking at this, but we're also looking at the condition of the joints. So yes, and when it comes to a patient that may be at risk of sleep apnea, the cone beam evaluation of the patient is a justified radiology image to be captured, because it's going to provide you with the additional data to understand what is contributing to the patient's inability to breathe properly, and more importantly, what's causing them to have potential sleep apnea or snoring difficulties at night. So that's the justification for this type of image. And as I mentioned already, the dosages are within dosage levels that are equivalent to some of the other images that you take in your traditional practice with other radiology equipment, right? And I think that in that regard, Jim or Paul, you could even speak in more detail to the type of exposure that patients are receiving with cone beam technology in general.
Right, and Sal, I think we have I talk to my doctors about this, is, when we're doing the initial scan, a lot of times we'll take our initial scan, but we also have our low dose setting, which will lower the dose even more. And maybe we can talk more to Dr. Atai about that, on how he's implementing in this office his initial scan, post-op scan, which kind of leads us right into one more question we have. Do patients complain of snoring, tiredness, and headaches with sleep disorders? Basically, are there other indicators of sleep apnea in dealing with patients reporting other issues? And, we can probably, so I think you touched on a lot of these, but this will be a really good lead-in for Dr. Atai to talk about here's other things that we deal with and other recognitions, or if there are other things you want to share today, Sal, this would be a good kind of highlight for our next session.
Yeah, no, I agree. We will definitely talk in more detail at our next session about it. But in summary, as I indicated earlier, the typical signs and symptoms that we tend to find in dental patients are going to be occlusal wear issues, right? Fractions, bruxism, joint dysfunction, patients that have, daily headaches, whether it be at night or daytime, patients that complain of not just feeling excessively tired, but an inability to focus, patients that report waking up frequently in the middle of the night to urinate. There is a laundry list of signs that are indications of patients that may be suffering from these conditions. Again, I want to point you back to the white paper because there are a few articles that are recommended for reading there that will give you that information. But more importantly, I think in our next session, we do dive into a more detailed discussion related to these physical signs and symptoms that you will find in your practice. I mean, just the same patient that is at the hygiene chair that falls asleep the minute that you put them on the chair, that in itself is enough justification for you to prescribe a sleep study on a patient, whether the patient reports that they have a potential sleep disorder to you or not, right? Because again, you as a clinician, as a physician of the oral cavity and the adjunctive structures, it is within your scope to prescribe these type of studies if you have a high suspicion that the patient may be suffering from a sleep condition.
Right. Sal, we are almost to the bottom of the hour. We have two other questions, which I think we can answer pretty quickly. Number one, can sleep appliance cause side effects? I think, yes, joint issues, other areas is the simple question. Maybe we'll have Dr. Tai, and we can put that as part of our next presentation. And then one question for you is, can a patient snore at night without having OSA?
Yes, that's right.
And
yeah. You could be just snoring and not necessarily suffer from obstructive sleep apnea, and you could be a sleep apneic and not snore. That's why we need to properly evaluate patients for airway deficiencies to definitely understand what's going on at night. And I also want to make one point of clarification. We talked a lot about cone beam technology today, and I want to clarify that the cone beam images are not diagnostic for sleep apnea or sleep disorders. Only sleep studies that are prescribed and read and interpreted by a sleep physician could give you a conclusive determination if the patient is a sleep apneic or not. However, the cone beam images are able to provide you with diagnosis for dental comorbidities, right? You'll be able to identify any and all related dental comorbidities that the patient is suffering from, and it's going to provide you with all of the data necessary to properly develop a treatment plan so that you know how to best handle the patient. And it's going to give you the clinical data to also refer the patient to other clinicians that could help improve the patient's condition. One quick example is what I showed you earlier on the second case example, where we had a patient that suffered from nasopharyngeal problems. An ENT would be an appropriate referral for that patient, but that same patient also had cervical spine problems, right? Because they had developed that military neck. So the utilization of the cone beam technology is not just isolated for your utilization from a dental perspective, but it's also vital as it pertains to the coordinated managed care that these patients will need as you treat them for the immediate needs and long-term.
Right. Well, I think that brings us to the bottom of the hour here, Sal. Thank you for your time. Thank you for your knowledge and presentation. Let's talk a little bit. I guess the next step is the CE for the patients there. Did you have a slide on that one?
Not for the patients. I'm only going to give CEs to them.
Yeah,
I do, but I don't. Can you see my slide right now?
I'm going to send it back to you really quick. So you should be able to just say, show your screen.
Yeah. Okay. So again, this is a reminder for our next event. I think you already said it's September 2nd, right?
Yes,
And
correct.
simply visit our website at sleeparchitects.com/CE and enter the webinar code Vatech 0805. And if you have any problems completing the form or receiving the CEs will take between 7 to 10 days for you to receive as we matriculate all of you in the next few days. So with that, that's all I had to share.
Gotcha, Sal. Thank you so much for your time today. We look forward to working with you in next month. And to all of our Vatech family, please stay safe. Let me get to my screen here. And thank you for joining us today. We look forward to working with you either in September 2nd, or if you are so inclined, check out our website for the Vatech Fast Track Friday, the short a la carte sessions that are going to be August 21st. Until then, again, Sal, thank you for your time and your knowledge. Paul, thank you. Vatech family, stay safe, and we will talk to you soon. Thank you very much.
Take care, guys.